Hello and welcome to the topic Chronic Obstructive Pulmonary Disease or COPD in the module Respiratory Medicine. By the end of this topic, you should be able to define COPD, discuss the epidemiology, outline the pathophysiology and causes of COPD, outline the classifications, describe the clinical manifestations of a patient with COPD, outline the investigations, and discuss the principles of management as well as the complications of COPD. Let's get started. According to the Global Initiative on Obstructive Lung Disease or GOLD, chronic obstructive pulmonary disease or COPD, in short, is a preventable, treatable disease characterized by airflow limitation but not fully reversible. The old term COPD is referred to emphysema, which means destruction or enlargement of the alveoli, and chronic bronchitis, which presents with chronic cough and phlegm. The prevalence of COPD is about 16% among men and about 10% among women and 14% in the US general population. COPD is more common in older people who are more than 65 years old. The strong associated factor here is smoking. Let's discuss the normal mechanisms of breathing. Lungs, chest wall compliance, respiratory rate, and airway resistance work in conjunction to create negative pressure in lungs and the pleural space. This allows air to be drawn into the lungs. When there is a drop in lung volume, the pressure in the lung increases, hence air is forced out from the lung. Respiratory rate is based on supply and demand of oxygen. When the oxygen demand increases and carbon dioxide builds up in the body, respiratory rate will increase to facilitate gaseous diffusion. During inhalation, diaphragm moves downwards and intercostal muscles pull rib upward and outward. This increases the chest cavity and air is drawn into the lungs. During exhalation, the diaphragm moves upwards and the chest wall muscles relax. This reduces the chest cavity and the air is expelled out. When oxygen reaches the alveoli, it diffuses from the alveoli to the blood through the capillaries lining around the alveolar walls. Oxygen binds with hemoglobin to form oxyhemoglobin in the capillaries. Oxygen is transported to the cells by hemoglobin bounded to the red blood cells. When they reach the cells, oxygen uncoupled from hemoglobin and moves into the cells. Carbon dioxide from the cells diffuse into the capillaries and bind to hemoglobin in the red blood cells to form carbaminohemoglobin. Red blood cells will then carry this deoxygenated hemoglobin returning to the heart via the veins. Heart pumps this blood into the lungs and carbon dioxide diffuses into the alveoli during exhalation. After years of damage caused by inhaled toxic materials such as cigarette smoke, there is hypertrophy and hyperplasia of goblet cells in the mucosa of the bronchi. This results in an increased production of mucus whose removal can no longer be guaranteed by the ciliated epithelium. The lumen of the bronchi is constricted and therefore promotes a lasting inflammatory reaction. This inflammation leads to a remodeling process, so the obstruction is both functionally and structurally permanent. Another consequence of chronic inflammation is a non-physiological ratio between proteases and protease inhibitors, so that there is destruction of connective tissue leading to damage of the supporting structures of the lungs and development of pulmonary emphysema. The elasticity of the lung decreases, the residual volume increases. The affected patients have to increase their work of breathing. Obstruction of the respiratory tract causes interference in the distribution of air, which leads to pulmonary vasoconstriction of the hypoxic areas. If the total cross-section of all pulmonary vessels continue to decrease, this may cause pulmonary hypertension or even pulmonary heart disease. The causes of COPD include smoking, alpha-1 antitrypsin deficiency, and other causes such as exposure to cadmium used in smelting, coal, cotton, cement, and grain. Smoking is still the most common cause of COPD. Alpha-1 antitrypsin deficiency is a common inherited condition, inherited in an autosomal recessive or codominant fashion caused by a lack of a protease inhibitor normally produced by the liver. The role of alpha-1 antitrypsin is to protect cells from enzymes such as neutrophil elastase. Genetically, it's located on chromosome 14. The alleles classified by their electrophoretic mobility, M for normal, S for slow, and Z for slow. NICE recommends considering a diagnosis of COPD in patients over 35 years of age who are smokers or ex-smokers and have symptoms such as exertional breathlessness, chronic cough, or regular sputum production. The following investigations are recommended in patients with suspected COPD. Post-bronchodilator spirometry to demonstrate airflow obstruction. If the FEV1 over FVC ratio is less than 70% with normal total lung capacity. Chest X-ray would depict hyperinflation, bullae formation, a flat hemidiaphragm, and also important, it is done to exclude lung cancer. A complete blood count is done to exclude secondary polycythemia. NICE recommend considering a diagnosis of COPD in patients over 35 years of age who are smokers or ex-smokers and have symptoms such as exertional breathlessness, chronic cough, or regular sputum production. Spirometry is the mandatory investigation to assess the severity of COPD according to the GOLD classification and aid the management. FEV1 over FVC in COPD patients is less than 0.7 with FEV1 reduced and partially reversible less than 15% post-bronchodilator therapy. Chest X-ray may show hyperinflated lung fields, bullae, and flat hemidiaphragm. Alpha-1 antitrypsin tests can diagnose COPD secondary to alpha-1 antitrypsin deficiency. A full blood count and arterial blood gas can be done to look for secondary polycythemia and respiratory acidosis among COPD patients respectively. COPD is classified according to the GOLD classification based on the FEV1. There are 4 grades, grade 1 to grade 4. GOLD 1 is considered mild obstruction with FEV1 more than 80%. GOLD 2 as moderate obstruction with FEV1 50 to 79%. Severe obstruction is GOLD 3 with FEV1 30 to 49% and very severe obstruction GOLD 4 with FEV1 of less than 30%. This grading is an assessment of airflow limitation. It will combine with the assessment of symptoms and risk of exacerbations for further management. The assessment of severity has 4 classes too based on the exacerbation history and symptoms. Class A and B patients are the patient who has none or one history of exacerbation in the past 1 year which do not lead to hospitalization, while Class C and D are for those who had 2 or more exacerbations or any exacerbation that led to hospital's admission. If the patient has symptoms with MMRC 0 to 1 or a CAT score less than 10, they are categorized as A or C, while MMRC 2 or more than CAT score at least 10 points, they are categorized as B or D. ECG is a test done to look for right ventricular hypertrophy, arrhythmias, and cor pulmonale, which are the cardiac complications of COPD. Let's discuss the principles of management of COPD. During an exacerbation, bronchodilator therapy such as a short-acting beta-2 agonist or a short-acting muscarinic antagonist can relieve the symptoms. If a patient remains breathless or more exacerbation, the next step would need to be determining whether asthmatic features or features suggesting steroid responsiveness are present. According to the NICE guideline, asthmatic features are as follows. If there are any previous diagnosis of asthma or atopy, higher blood eosinophil count, substantial variation in FEV1 over time, at least 400 mL, and substantial diurnal variation in peak expiratory flow. The NICE has updated its guidelines on the management of chronic obstructive pulmonary disease in 2010. As for bronchodilator therapy, a short-acting beta-2 agonist or short-acting muscarinic antagonist is the first-line treatment. For patients who remain breathless or have exacerbations despite using short-acting bronchodilators, the next step is determined by the FEV1. If it is more than 50%, long-acting beta agonist, for example, albuterol, or long-acting muscarinic antagonist, for example, tiotropium, is initiated. If the FEV1 is less than 50%, a long-acting beta agonist plus inhaled corticosteroids in combination inhaler or long-acting muscarinic antagonist is initiated. NICE only recommends theophylline after trials of short and long-acting bronchodilators or to people who cannot use inhaled therapy. The dose should be reduced if macrolide or fluoroquinolone antibiotics are co-prescribed. Mucolytics should be considered in patients with a chronic productive cough and continued if symptoms improve. Factors which may improve survival in patients with COPD include smoking cessation, which is the single most important intervention in patients who are still smoking, long-term oxygen therapy in patients who fit the criteria, lung volume reduction surgery in selected patients. The 2010 NICE guidelines on COPD clearly defines which patients should be assessed for and offered long-term oxygen therapy or LTOT. Patients who receive LTOT should breathe supplementary oxygen for at least 15 hours a day. Oxygen concentrators are used to provide a fixed supply of LTOT. Assessment is done by measuring arterial blood gases on 2 occasions at least 3 weeks apart in patients with stable COPD on optimal management. Offer LTOT to patients with a partial pressure of oxygen of less than 7.3 kPa or to those with partial pressure of oxygen of 7.3 to 8 kPa and one of the following, which include secondary polycythemia, nocturnal hypoxemia, peripheral edema, and pulmonary hypertension. Next would be lung volume reduction surgery, which is done in selected patients. If the partial pressure of carbon dioxide is 7.4 and above, if there is severe limitation of exercise capacity despite maximal therapy, if the predominant upper lobe is emphysematous, and if there is persistent symptoms despite a period of pulmonary rehabilitation. The short-term complications of COPD include recurrent pneumonia and pneumothorax. The long-term complications are cor pulmonale, polycythemia, lung cancer, and also this may lead to depression. In summary, chronic obstructive pulmonary disease is a preventable, treatable disease characterized by airflow limitation but not fully reversible. The old term includes emphysema and chronic bronchitis. Smoking or alpha antitrypsin deficiency contribute to alveolar structural changes and narrowing as well as remodeling of the airways. The gold classification is the classification of COPD. Important history of COPD include productive cough, exertional dyspnea, wheezing, and smoking history. The clinical signs are respiratory distress, barrel chest, hyperresonance, reduced breath sounds, wheezing, coarse crackles, cyanosis, signs of right heart failure, and any evidence of CO2 narcosis such as asterixis. Spirometry is an important investigation. Results of spirometry in COPD include FEV1 over FVC less than 0.7 and FEV1 reduced with 15% reversible post-bronchodilator. When it comes to management, a short-acting beta-2 agonist or a short-acting muscarinic antagonist is the first-line therapy. You may then add a long-acting beta agonist or long-acting muscarinic antagonist or inhale corticosteroids if the symptoms persist or increase exacerbation. Other management includes smoking cessation, pneumococcal or influenza vaccination, and consider long-term oxygen therapy as early as possible to improve survival. The complications of COPD include recurrent pneumonia, pneumothorax, cor pulmonale, polycythemia, and lung cancer. We have come to the end of this topic. Thank you.